Thank you very much. I'll go on to the last topic, and this is as regards trying to get accuracy in cataract surgery, because today cataract surgery is not just a restorative surgery. It is also a refractive surgery, and being the most commonly performed surgery in the world, we are looking at refractive outcomes wherein the dependence of glasses for the patient is reduced post-operatively. Now, it may tomorrow, with a good multifocal intraocular lens being there, it could become a treatment for choice for presbyopia. Now, when you're looking at refractive cataract surgery, what are the essentials that you wish to have to get to the target emetropia? The first thing is that you should have a perfectly size-shaped and positioned capsular axis, because this is going to determine the effective lens position. And once you have a good effective lens position, the A constant can be looked at, and therefore the IOL power calculations becomes more accurate. Now, furthermore, you look in refractive cataract surgery to not cause any collateral damage onto the cornea, and therefore the lens fragmentation should be as atraumatic as possible. Furthermore, the incisions, you need to know as to what is your surgically induced astigmatism, and in case of a blade, that could be a little problem. So if you have a laser-assisted incision, that could take care of it. And the fourth thing that the femtocataract would do is to look at arcuate incisions. When LRIs came earlier with diamond knives, they were unpredictable, but I think the predictability is now getting better. Now, the femtolaser-assisted cataract surgery tries to address all these issues, and it was approved only in the year 2010 and was available commercially from 2011. There are 4 companies which have the approval from FDA, and these are available commercially, all 4 of them in India. Catalyst and Lensex having close to 40-45 installations each in India. Now, this is the capsular axis. If you see the capsular axis that is done by a femtolaser and a capsular axis that is done by a trained individual, you can see that the outcomes would be reasonably different. Now, it has been shown clearly that the fragmentation of the lens, if done earlier or a pre-chopping done earlier with a femtolaser, that would reduce the energy that is required for aspiration. The self-sealing incisions can be tailor-made, and you can position them exactly as to where you want. And the fourth thing, which actually is a game changer now for smaller degrees of astigmatism, whom you do not want to put a toric intraocular lens, would be to form arcuate incisions. Now, there is a simultaneous OCT that is there, and therefore you can position precisely, and you can also know exactly the depth that you want, and the arcs would give you good results as is being shown. Now, this is important in the femtocataract, that it is a simultaneous imaging. That means that you have an in vivo image of the front part of the eye with an OCT, with different types of OCT are there, and this is the placement. So this is, when you get the picture, this is the anterior capsule which is sandwiched between the 2 lines, and this is the amount of lens that needs to be fragmented, and you get the OCT image of the cornea for the LRIs also. Now, when you look at the catalyst system, that was the Lensex system, this is the catalyst system. It is a liquid interface, and therefore it is the fastest capsular axis that happens. There is an automated centration, plus there is an automated tilt compensation. Now, this is the ways you can liquefy the nucleus, and you can see that these are, you can make 4, 6, 8, and you can do from medium to hard cataracts, the softening of the nucleus. And this is what you have, the matrix pattern that is there in the Alcon machine. Now, lens fragmentation actually comes out in vogue. You see the best advantage when you are looking at hard cataracts, and this is much advantageous in getting a clear cornea post-operatively. Now, when you are looking at a liquid interface, this is how you work on it. The suction amount is very gentle, and you do not get any cherry red spot, and the patient is not inconvenienced during the procedure. Now, tilt compensation is important, and you can see when you get this OCT, this is the amount that you're leaving as the uncut area, the red area, and this is where you have the lens fragmentation, so you have a safety zone, and the tilt is compensated in all. Now, I'll just show you a small brief video, and we will just after that just show you 2-3 slides on the astigmatism. You can see this is the locking of the eye. This is the incision that you can position the incision. You can see that the capsulotomy has taken place. This is the fragmentation that is happening And you can see that once the fragmentation has happened, these are clear 4 quadrants that are there, and this is the softening that is happening. Now, after that, the next thing that comes in is the incisions that you can see. You can see that this is the primary incision, and this is the secondary incision that is being created in this. Now, you can go ahead and see this, that the incision opens pretty well. This is on the catalyst machine. You can see that it's almost a free-floating capsulotomy. When you are doing a hydrodissection, you just need to burp the fluid, and you can see that the softened nucleus is very easy to aspirate out, and you can see that it is almost pre-chopped. This is the markings, etc., that you have, and at the end of the procedure, you will see that it is a pristine, clear cornea with a fantastic capsulorhexis that you have. So this is the advantage that you have with a femtocataract procedure, that you are very clear as to what your outcomes would be. So it gives you precision, accuracy, and repeatability. This is just to show you a hard cataract, and in a hard cataract, this is the earlier machine that I used to use, that is the Lensex, and you can see that we have made the chops here. This does not have a softening pattern at that particular time. You can see that the capsulorhexis is fine, and you have taken out the capsulorhexis, which has come out perfectly. Now just watch that this is the hydrodissection that we have done, and I will just show you that the cleavage. Can you just watch this? You can see that this is an area, and you can see that the cleavage has gone despite a grade 4. Could you see that bubbles coming out? And again you see this is already pre-cleaved, and it's almost a black cataract. So you can see that it works pretty well even in hard and black cataracts, and therefore reduces the amount of energy. And this is post-op day 1 in the same patient that you saw. Now the final thing is that astigmatism control. All incisions you do on steep K, and then coexisting astigmatism, you have the Donald-Fields formula, which you do. I typically use a toric lens if the astigmatism is more than 1.25 to 1.5, and these are the LRIs that have been made. And we have an ongoing study that is there. We have done 20 eyes, 3 months follow-up, and you can see that mean preoperative astigmatism was 1.25 diopters, uncorrected visual acuity 20/20 in 17 of these 20 eyes. This is the amount that we have at 3 months. We still need to go to 6 months to see as to how this astigmatism correction is. So mean residual astigmatism was only 0.24 diopters, ranging between 0 to 5 diopters. So the LRI has given another dimension of giving you enhanced predictability in these cases. So femtolaser assisted cataract surgery is a refractive cataract surgery today, and has brought us closer to the aim of emetropia, and is giving you outcomes that are pretty much good, even when you have to treat coexisting astigmatism, and it is reducing the phaco energy and time. So the difference is obvious, and if you are looking at cataract surgery as a refractive surgery, you need to move on towards the femtolaser assisted cataract surgery. And this would take you to the goal of perfection and great outcomes. Thank you very much for your kind attention. Thank you.